So the genomics of MPN have really begun to move from helping us understand the basic biology of the disease into being utilized in clinical practice. We know that there are three main drivers of MPN pathogenesis, mutations in JAK2, MPL, and calreticulin, all of which activate the JAK-STAT pathway. It's important to recall that there are about 10 to 12% of patients for whom a driver mutation is not identified. Of course, this has been part of the key to targeting drugs such as JAK inhibitors for use in these diseases. But importantly, a lot of work over the past, I would say, decade or so has allowed us to understand that the genomics appear to have prognostic implications. So if we think about myelofibrosis, where I think this has probably been best studied, we know that things like mutations in ASXL1 or SRSF2 or IDH or EZH appeared to have the implication of an increased likelihood of disease progression, particularly leukemic transformation. And this list is growing. It's important to remember that as we sequence more and more genes, this list may and likely will increase. And we know that other genes such as RAS pathway mutations and mutations in U2AF1 also appear to have implications for disease progression. And what this means clinically is that when we assess a patient clinically for the first time or at any time in their disease course, utilization of the genomics can help us give the patient some perspective on what their likelihood of disease progression is. And that may have implications for aspects of their care, including whether or not to consider an allogeneic stem cell transplant. Along those lines, it may also have other therapeutic implications, and that may include targeting some of these mutations. A good example of this is IDH1 and 2 mutations, where we have FDA-approved drugs that can target IDH1 and IDH2 mutations. And in fact, there is an ongoing clinical trial that's combining Ruxolitinib and Enasidenib, an IDH2 inhibitor, for patients with accelerated and blast phase MPN, as well as chronic phase MPN patients who have been refractory to therapy. So we've really gone from knowing and describing the mutations to understanding what their implications are, to now making the first attempt, I would say, to using that information to better target disease pathogenesis. There still remains many biological questions that are unresolved, and I think one of the important things that has emerged in the last year is the understanding that JAK mutations may arise very, very early on in the patient's life, prior to there being clinically notable disease. And that raises the question of how and why does that latency occur? Are there other factors that mitigate the progression from simply having a JAK-STAT driver mutation to actually driving it to fulminant clinically obvious disease? I think that's an important and as yet unresolved question. So, to summarize, the genomics over the last several years have given us a lot of keys in terms of understanding the disease biology, but importantly, have also led to clinical prognostication, which is clinically actionable in some cases.